This evening I have the pleasure of introducing Ms. Grace Marie Turner. She is the president and founder of the Galen Institute and founder of the Health Policy Consensus Group. She is a recipient of the 2007 Outstanding Achievement Award for Promotion of Consumer-Driven Health Care from Consumer Health World. Founder and president of our Net & Company, a health policy analysis firm, Ms. Turner testifies regularly before Congress and in 2013 was named by Speaker of the House to serve as a member of the Long-Term Care Commission. She has written for numerous publications, including the Wall Street Journal, the New York Times, and the USA Today, and has appeared on many television and radio shows, including ABC's 2020. She is co-author of Why Obamacare is Wrong for America and editor for Empowering Healthcare Consumers Through Tax Reform. Please all join me in welcoming Grace to the stand.
Hello, everyone. Thank you so much for coming out on this rainy afternoon, and even more for inviting me to Hillsdale. This is my first chance to visit this really famous campus that I have admired from afar for such a long time, and I really am grateful to be with you here today to talk with you about health policy and how we can sort out the mess that we are in. I think it was P.G. O'Rourke who said, "You think health care is expensive now, just wait until it's free." Absolutely true. Thank you, Bernie Sanders, just in case you want to wonder what's going on. So just a little talk about where we are and the stage setter. There's really not a lot of disagreement about the goals of health reform. We want to make sure that everybody has health coverage. We want to make sure that the health care and coverage are both affordable. We want to make sure that we have good quality of care. And we also want to make sure that people have choices. If you like your doctor, you can keep your doctor. If you like your coverage, you can keep your coverage. And I think most importantly, as Americans, we want to make sure that the most vulnerable in our society have opportunities to get the care that they need. So how are we doing with that? Not so well. The Congressional Budget Office just released some new data that I think puts it in a larger perspective, particularly for young people today who are going to be inheriting mountains of debt from the entitlement programs that we have today. And I think hopefully this will give some indication of why it's so important for us to do health reform. When you look at this chart, you can see how much of the federal budget, and also our health sector is currently being financed through government programs. We spend about $3.1 trillion this year on health care. Almost half of it goes through government programs, Medicare, Medicaid, and the Children's Health Insurance primarily, but also the Veterans Administration, the Indian Health Service, and only half is financed through private programs. But when you look at this, you can also see that the small percentage, I used to have a pointer here, the small percentage that consumers actually pay out of their own pocket, 11%. They're financing the whole thing through taxes, through reductions in their wages, through deficit spending, but only 11% actually comes directly out of their pocket and out-of-pocket expenditures. So imagine if we had an automobile industry where people only paid 11% of the cost, and by the way, had no idea how much it was going to be before they spent the money. What a mess we'd have in people being able to purchase an affordable automobile. Well, that's really where we are in our health sector, and one of the reasons that we've got to get it back to more of a market-based system. And we'll talk a little bit about how to do that. So this is again a new CBO chart that shows how dramatically important it is to begin to reduce even just a bit the spending on health care. If we were to keep prices, this is over the long term, thinking about this until 2045 is the date here, sorry I have to look at this, that if they were to if health costs were to grow at just 1% or lower, then the rate of what they call excess growth on federal spending on Medicare and Medicaid was grown by 109% over the next several decades. If it grows at 1% or higher, it's double that. It goes up to 206%. So just a small reduction in spending can make a huge difference over time in what this does to the federal deficit. And look at this, the projection of where we are with federal debt held by the public. This goes back all the way to the beginning of the country, and you can see in 1790, after the Revolutionary War, there was a pretty significant debt held by the public. The spikes you see are the Civil War, World War I, the recession, World War II, but look where we are now, where we're headed. And this is almost exclusively because of entitlement spending and debt payment, financing the debt. So we really must address this. And Obamacare took us completely in the wrong direction, as you will see, as you already know, but I'll have some data to show you. So we've got to begin to move the needle back toward individuals controlling more of their choices, but importantly, having the incentive to spend those tax dollars and those health care dollars wisely so we don't add to the mountains of debt that we are facing that really do, I believe, compromise the future of our freedom and our liberty in this country. So let's drill down a little bit now and talk about the Obamacare world and what has happened over the last really decade, because we started this debate in 2007, 2008 over health reform and what this is going to mean to our country. So, you know, you have to acknowledge that there has been a major reduction in the number of people without health insurance. We started out with 44 million people not having health insurance before the Affordable Care Act, Obamacare, passed. And in 2016, we had 28 million people who were uninsured. So that's a net reduction of 16 million people that previously were uninsured that are not now. So that's, you could argue, a significant public policy achievement. Do they have access to care? Not necessarily, but they do have an insurance card. And look where the major coverage has come from. Almost exclusively from expansion of Medicaid. A lot of people lost their private health insurance, both their individual policies, even in their job-based coverage, particularly with people that worked for small companies. But the net increase, almost 90% of the net increase in new coverage was through Medicaid, another entitlement program that has to be financed through deficit spending and through higher taxes. And when you look at what did this do to private coverage, well, in the Obamacare exchanges where people can get private health insurance, this is apart from Medicaid, you had about 9 million people getting subsidies to purchase health insurance through the exchanges. You had another 9 million people that were getting coverage in the individual market, this required mandated coverage under Obamacare, but they weren't getting subsidies. Those are the people who are really ticked off right now because of the huge, huge cost increases that they're facing in their coverage. But remember, they're mandated to buy it. So either they pay that or they pay, thank you, Judge Roberts, a tax. About 3.5 million people lost job-based coverage. Walmart, for example, looked at the numbers, and Walmart, a good company that was doing a lot to provide options for people in getting good health insurance coverage. They basically said to part-time workers, you're better off in the exchanges because you're going to get a lot more help with your insurance premiums if you go into the exchanges. So we're dropping coverage for part-time people, many of them even on Medicaid. The net increase in coverage, in private health insurance coverage, for all of the turmoil that we have gone through over the last 8-10 years, 1.7 million more people now have private coverage than did before. There surely had to be a better way to go about doing this, and we're going to talk about that. The individual mandate. This was the mandate that was, but truly is the most unpopular part of this law and the one that most challenges our freedom. I see some heads nodding. That tells you that the federal government is going to determine how you are going to spend a significant and growing part of your personal income on a product, a private product, that the government forces you to purchase. We and many others wrote amicus briefs when the Supreme Court was arguing this case, saying this is unconstitutional, but Judge Roberts says, no, it's a tax. And therefore, when the government does have a choice, you can either buy the insurance or pay a tax. So you have a choice. Well, for a lot of people, that's not much of a choice. I had an Uber driver recently who said that he had taken this part-time job because it was the only way he could afford health insurance for his family. He said, my health insurance now costs more than my mortgage does. And people are finding that increasingly, we're going to talk about costs in a minute, but the costs of health insurance are increasing dramatically, so people are now required to buy this hugely expensive policy that is getting more and more expensive, and it's not an option. They have to purchase it or pay a fine. Congress gets it and has tried 4 times to try to get reform legislation over the top, and I'm going to talk with you in a minute about what was in those bills, which is probably going to be news to you based upon the way that the news coverage of those bills. But they really can't give up. I believe obviously they are and should be focused on tax reform right now, but I believe they have to come back to this issue in 2018 to try again, and we're working very hard to try to put together a product that learns from the lessons of the last year so that we can shape this product, this health insurance legislation, in a way. I see a head nodding. They're going to do that. They have to. The reason they have to do this is, and I've actually talked with members who said, I am going to be primaried by people who are saying that I failed to get Obamacare repeal legislation through Congress and they need to elect a different Republican to pass this legislation. So they are, and those primaries happen in the first part of next year. And they certainly don't want to go to the voters next fall and say, you know, we told you for 4 election cycles we were going to repeal Obamacare. It was just too hard. They can't do that. They have to try again. And this time, with a bottom-up process where people feel more engaged, the leadership felt it was so important to get Obamacare repeal and replace legislation through that the leadership ran this from the top down. And we're going to get this perfect. We're going to get this legislation exactly right. But the members did not feel engaged. They couldn't explain it. They were as vulnerable as the American people were to hearing about small parts of the legislation, not understanding the bigger picture of what it would do. And then finally, John McCain, with his thumbs down, killed the whole effort. But we're coming back at it. We're going to do this. So the reason we have to do it is because the American people are hurting more than ever over this legislation. And since 2013, that's the year before the Obamacare exchanges and mandates went into effect, premiums have risen 99% for individuals, 140% for families. And that's on average. Costs for a 27-year-old, let's say you just got off your parents' policies, a 26-year-old had parents who had health insurance at work, kept him on the policy. He would have spent about $2,600 for a policy the first year of Obamacare. This year, $4,900. What 27-year-old just starting out is going to be able to afford $2,700 in premiums, probably without much help from the federal government in paying them? And in any case, that's too much money for health insurance. Young people are being forced to pay a much higher percentage of the cost of expansion of health insurance than older people. They made a decision, oh, we're going to just make the 27-year-olds pay more so we can charge 55, 60-year-olds less. it's completely unbalanced as far as the resources that that 26 or 27-year-old has. The average price increase for coverage this year is 37% of 1 year for 2018. And many people are not going to have a choice of plans. They're going to have a sort of a take it or leave it plan in your area. If they're lucky, they may have two choices, an HMO and one of the health insurance companies that are all cookie cutter plans anyway, because they're all defined by the federal government. This is shows in 2015. Only 6% of people lived in counties that only had a choice of one insurer. But by 2017, 33% did. And next year it's going to be about half of people live in counties where they really don't have a choice. Buy this health insurance that the federal government is making you to buy or pay a fine. This is not okay. They have to come back at this. So here, what is their plan? Well, this year they thought we just have to pass something. Even if it's not perfect, let's get something through. The market stabilization, I think this is the bipartisan bill that Senator Alexander from Tennessee, Republican, and Senator Murray from Washington State, Democrat, are trying to put together. I don't think that's going to go anywhere. But as I said, I do believe they're going to return to repeal and replace legislation in 2018. But also behind the scenes, there's a lot going on with regulatory action. This bill, and the slide I'll show you in a minute, this bill gave the Secretary of Health and Human Services 2,000 different powers to run our health sector. And that was not good news under the Obama administration. But the Trump administration, there are good, smart staffers working both in the White House and at the Department of Health and Human Services that are really diving down into the weeds of these regulations and looking for opportunities to roll back regulations, to use executive actions to give people more choices, and also inviting people to come up with innovative ideas so that they can do even more over the next 3 at least years. And then Congress also is looking at the possibility of regular order bills. There are a number of pieces of the Obamacare bill that have bipartisan opposition. One is the Independent Payment Advisory Board. This is what we call the death panel. This is where these 14 bureaucrats that have no judicial review and basically no congressional review are able to set and therefore cut prices in Medicaid. And there are a number of Democratic leaders who say this is not constitutional. They cannot set payment policy without being elected representatives. So I think that's something that we might be able to get bipartisan. The House actually passed on a bipartisan basis with 44 Democrats crossing over to pass this out of the House. A heavier lift in the Senate, but I think they'll look at that. Other things like making tax credits available for COBRA insurance. This is the insurance that you get to keep often after you leave your employer. Giving TRICARE veterans eligibility for tax credits, and doing some things for small businesses, which again have a lot of bipartisan support. So once we get past sort of the big bulb of what we do with Obamacare, I think there will be the opportunity for other legislation. I thought if they would have gotten this done earlier this year, we could be in that season now. It's probably going to be hard for them to do it in an election year in 2018. But I think they will likely come back at this in 2019 to do some of these things on a bipartisan basis to fix the bill. But so far, not going so well. Car wreck. So, repeal, replace, retain, retreat, what are we going to do here? The American Health Care Act finally passed the House May 3rd. Senate failed on July 28th, and the final attempt to pass a Senate bill was pulled from the floor when they realized Senator McCain was once again going to vote against it, as was Senator Collins from Maine and Senator Murkowski, all Republicans, basically killing the health reform effort. But this little video seemed to really sort of encapsulate this. Happily going along. Just crashed and burned. That's why they need to start this from a different direction. So let's talk, though, about the core provisions of the House and Senate bills, because there were a lot of similarities in those bills, and I think that they are likely to provide much of the structure for health reform legislation going forward. Nobody was going to lose their current coverage. Did you hear that? No. Both bills, all of these bills in both houses, would have said if you are receiving coverage now, you're getting health insurance. Many people who lost coverage against their will, the policies were canceled, their employers dropped it, they don't have anywhere else to go, and this coverage is much more expensive than they can afford. We cannot have them, we can't have those 16 million people suddenly losing coverage, so they would have continued a support system for them to be able to keep that coverage until a new system was put in place. It would have preserved the expansion of Medicaid. There would have been different ways that they would have begun to roll that back. It would have also, as I said, provided subsidies to help people keep their health insurance. And just as an example, in the House bill, the subsidies for health insurance for a family would have gone up to $14,000 a year to keep their health insurance. So they were not pulling the rug out from the American people, as the media would have us believe. Importantly, they would have repealed all of the taxes in Obamacare, $1 trillion in taxes. 20 new and higher taxes would have been repealed. They would have allowed young people to stay on their parents' policies. That's sort of now a given. It would have repealed the awful individual mandate and the employer mandate, gotten rid of them, given us our freedom back. Also, importantly, and this I think is going to be the key provision for going forward, it would have given states a lot more flexibility in how they spend both their Medicaid dollars and the money that's coming to citizens in their states to purchase health insurance. Right now, you may have, in one family, somebody on employer insurance, somebody on Medicaid, somebody on the Children's Health Insurance Program, somebody getting coverage through the exchanges. What a nightmare to try to manage all of those different health insurance programs in one family. And how incredibly expensive and wasteful it is to have all those siloed programs. So the states would have been able to merge those funds at the individual level to give people more choices and to approve plans that, amazingly, they may actually want to buy with these resources. So there were really good ideas in this legislation, but it hardly was able, and of course we can't forget protections for pre-existing conditions, because that's another political given that you have to build into your system. The final bill that just barely did not come to the Senate for a vote in late September was sponsored by Senators Graham, Cassidy, Heller, Nevada, and Johnson from Wisconsin. And this really came at the issue from a different perspective. Instead of having the same refundable tax credits to distribute money at the federal level, they said, you know, we've got to move toward a system of federalism. We've got to trust the states. We've got to give them resources, and we've got to make sure that they meet deliverables with how they are allocating these resources, but to give them the chance to begin to build their healthcare systems back up from the bottom up. It would have had no individual mandate penalties. They couldn't really get rid of the individual mandate through, and I should have said this earlier, through this reconciliation process. In order to get legislation through the Senate with a simple majority vote, everything in it, everything, has to be directly pertinent to federal spending or taxes. If it's regulatory, parliamentarian says, sorry, we're not only throwing that out, we may throw out the whole effort. So they're walking on eggs trying to figure out how can they give states as much power as they can, but do it through these financial systems. The only way to get rid of the individual mandate was to say, we can't get rid of it because it's a regulation, but we can make sure that you don't ever have to pay a penalty for not having health insurance, or employers would not have to pay a penalty. So that's how they were, through this single majority 51 vote in the Senate mechanism, going to get rid of the individual and employer mandate until we can elect enough people that would actually take it off the books for good. Taxes, this is not good, because they basically said, we're going to keep most of those taxes. We're going to keep the we're going to get rid of the medical device tax, again, something that has strong bipartisan opposition, but leave most of those other taxes in place. Not necessarily very good. We're working on this. But importantly, the funding would devolve to the states. One of the things that we've learned through this experience with Obamacare is the federal government is completely out of its element in managing something as vast and yet personal and regional as healthcare. The same policies cannot work for Missoula, Montana, Manhattan, and Miami, Florida. Those are completely different markets. They might as well be in different countries. We've got to give states and really even localities the ability to move those resources down to the individual level so that people are making choices of what works for themselves and their families in a more transparent system where people have more choices than they do with this federally mandated health insurance coverage, and give the states then some deliverables. You know, how are you doing in reducing the number of uninsured, rather than telling them every hoop they have to jump through. So the bill, I believe, is going to be the structure for health reform legislation going forward that is really built on the principle of federalism, so that the states begin to rebuild their health insurance markets. We've done some focus group polling, and people get it. They say, you know, federal government shouldn't be regulating my health insurance. I know my state legislators, or at least I feel that they are more likely to listen to me if I go to talk to them. And they want their states to have more control over the kind of policies that are available to them. But let's take a look at what happened in this debate, because you have to learn that in order to be able to know going forward, how do we need to address some of the problems that we ran into. So how many people heard that if these Republican bills were to pass, 22 million people would lose health insurance coverage? Yeah, right. Okay. Let's explain what that meant. This is the all-knowing Congressional Budget Office telling us that, right? The Congressional Budget Office ascribes almost magical powers to the individual mandate. They said that in 2018, just next year, if these bills were to pass this year, suddenly 14 million people would be uninsured. They wouldn't lose coverage because the subsidies weren't generous enough. Remember, they put $14,000 on the table for a family. No, it was because the individual mandate penalties would be repealed and people would just stop buying coverage. 5 million people would just drop out of Medicaid. For most people, Medicaid cost them nothing. But if they didn't have a mandate to be covered, they'd drop out of Medicaid. 2 million people would just drop their employer-based coverage because the mandate goes away. And 6 million people would leave the exchanges even though they're getting heavily subsidized coverage in the exchange. Makes no sense. But almost all, and then the 22 million was a 2014 number, almost all of the coverage losses were because the Congressional Budget Office believes that if we just wait long enough, the individual mandate's going to work. We're going to be able to force everybody to buy health insurance. We'll just have to make those penalties a little bit higher until people feel the pain. It's not going to work in our country. People are dropping coverage because they cannot afford it. Unless the coverage is more affordable, we're not only going to not be able to keep stable health insurance markets, we're going to begin losing the coverage grounds they've made. In fact, we already see it. For next year, we're going to see the individual market drop by 2 million people just because the costs are getting so completely out of hand. So this is just to show you exactly why we should not listen to the Congressional Budget Office. They thought that by 17, that we would have about 25 million people in the Obamacare exchanges. These are the people buying private coverage through healthcare.gov and the state's version of those subsidized health plans. Actual number, 10 million. But at the end of the year, more like 8.5, because people will sign up for coverage in the beginning of the year and then say, I just can't keep paying these premiums, and then they drop out. And why do they do that? It's because the incentives are, if you pay your premiums through September 30th, the companies are required to continue to provide you coverage through the first of the year, 90 days. And you can, by the way, go back and buy a policy from that same company for the premium you would have paid had you stayed continuously coverage. So there was an incentive for people to drop coverage, and they did it. And there was even worse, there were lots of incentives for people to not buy the coverage at all and wait till they're sick to sign up, which they also did. That's what the guaranteed issue provision. You're going to be able to buy a health insurance policy no matter what. Well, insurance doesn't work if you do that. But Congressional Budget Office seemed to really ignore that. So also, if you were to replace the individual mandate, what are you going to do that with? If you had health insurance, these were the House and Senate bills, if you maintained coverage, because what we want to do, health insurance only works if people pay premiums over time in case they get sick and need coverage. So it would have said if you maintain continuous coverage, then you cannot be charged more if you get sick or injured and need to use your health insurance. They also said if you didn't buy coverage, you would face, in the House bill, a 30% surcharge for a year. I mean, it's still not a huge premium, huge penalty for buying coverage. And the Senate said that if you dropped coverage and didn't have it, you had to wait 6 months until you could apply again. I'm not sure either of those is the right answer. I think the states actually could probably do a better job of figuring out if it's going to work, if we're going to have, good healthcare system, people need to participate. And how could we give them an incentive to do it? Well, the biggest incentive is to make it affordable in a product they want to buy, but also maybe to have a few sticks, but not something as onerous and expensive as the individual mandate. So pre-existing conditions also, everybody would have been protected. They only would have been able, states could only drop the pre-existing condition protections if they had a better idea. So we also have heard people are going to be bleeding in the streets, lying in the gutters, bankrupt if any of these House bills pass. But as you see, there were a lot of protections in here that they got almost no credit for. As I said, state could only waive the pre-existing condition if they had a better idea. So what's next? I think that a lot of regulatory action is going to be, certainly it's not easy, but it's easier than getting a bill, an act of Congress passed, clearly. The President announced an executive order last month that I think really can begin to free up the market. Expanding association health plans. This is allowing, let's say you're a small contractor in Hillsdale, and you can't afford, I don't know why this keeps doing this, you can't afford to purchase coverage for your 6 or 7 workers. But your national association, maybe the National Home Builders Association, offers you the opportunity to buy into their plan where they're aggregating lots of other small companies together so they can get volume and quantities and efficiencies of scale. That's, I think, going to be important and allow people to not be subject only to the regulations in their state. So it's sort of a twofer. It allows people to buy in volume and also to be able to have different regulatory structures. It also, and I think this is really going to be crucial, will allow people to purchase temporary policies. The Obama administration, in order to drive more and more people into the exchanges, basically said you can't buy a temporary policy that lasts for more than 3 months. What that meant was that somebody who's starting a business, moving between jobs, and they don't have the option for health insurance yet, couldn't buy a policy that lasted for more than 3 months. The Trump administration is rewriting the rules so that people can buy a policy for a year and it's not subject to all the rules and regulations and mandates of Obamacare, and they're going to be able to renew it. So this is a way of giving people an option of different kinds of health insurance that escape all of the Obamacare rules and regulations through this regulatory action that could, I think, just explode in giving people more opportunities and more options for coverage. And then finally, allow people to use health reimbursement arrangements, which is sort of a precursor of health savings accounts, but based in the employer model. The employer could put money aside into a funding account and allow people to use that money to pay for routine bills, and therefore be able to have a higher deductible policy, but still with the employer helping with some of the out-of-pocket costs. But importantly, the administration plans to allow people to use that money to pay for premiums, which they couldn't do before. And what that means is that if two people are working, a husband and a wife, both have the offer of health insurance at work, usually they have to decide which one to pick. Or sometimes worse, you may have one person on one policy and another on the other. The children may be even on sometimes a separate policy. This would say that you can use the money that the employer would have set aside for your health insurance to be able to buy one family plan to help with the premiums. You decide that you're going to use the wife's offer of employer-based health insurance, but the husband has a health reimbursement arrangement at his job. They can use that money to help pay the premiums. So this is going to make family coverage a lot more affordable, and once again, give people more flexibility. So these are just a few of the regulatory actions that I think are going to be possible with this administration actually looking to help people in purchasing affordable coverage. Imagine that, rather than trying to beat them over the head. So when you look at what is the reason, once again, another reason we have to fix this. You've heard a lot about, oh, the Trump administration is just stopping enrollment. They're not going to do anything to help people get enrolled in coverage. Well, the Obama administration spent more than $62 million last year on somebody called navigators. These were people who had often absolutely no experience with health insurance as health insurance brokers or health insurance agents who were signing people up for the exchanges. Navigators enrolled 81 million people with the $62 million in taxpayer money, less than 1% of the total. One grantee spent $200,000 and they only enrolled one person. So would it make sense for the Trump administration to say, let's just keep that program going? Absolutely not. And so they cut it in half. Oh my goodness, you would have thought that they cut people's arms off, and it was just awful. The reaction to stopping this wasteful spending on navigators. But they put a button on healthcare.gov, and they said, if you want to talk to a private insurer or private agent, who, by the way, may actually know something about health insurance, click here, and you'll be referred to somebody who actually knows about health insurance, who can help you enroll. And it doesn't cost the federal government anything. So there are better ideas out there. 78% of these navigators failed to meet their enrollment goals, and so, as I said, they're cutting it in half, and I think probably it's not going to affect enrollment at all, and actually it may help by having private agents providing help with them. So the final bottom line is that we've got to return power to the states. We've got to be able to do that, and it's going to require a change in federal law. It's going to require rewriting Obamacare and redirecting some of these subsidies and doing a better job than Graham Cassidy did of figuring out how to do that, to give the states more authority. And there actually is a provision in Obamacare which can't be repealed because it's a regulation, not a taxing and spending directly attributable to tax and spending, called Section 1332. You're going to hear that's a section of the law It's about a page and a half out of the 2,700 pages of legislation in Obamacare, which, by the way, has spawned about 50,000 pages of regulation. This is 1.5 pages that basically says to states, if you have a better idea about how to organize your health insurance markets, go for it. Give us some ideas. Well, under the Obama administration, they wrote the regulation about how Section 1332 has to work to be so strict that few states said they're going to try to do this, because they basically said, you can try to do Obamacare exactly the way we did it, but at the state level, and they said that does not help us. But this administration is going to rewrite those rules to give states a lot more authority and a lot more power. So keep your eye on that. It's called state innovation waivers. And it gives states more flexibility to restructure their programs, to do things like this family that I was talking with you about, to integrate the funding streams from all the different sources around the individual, around the family, and allow states to approve different kinds of health insurance policies than they're currently being forced to purchase, so that they can purchase the cover that actually works for them and their families. And they believe they have the authority to rewrite this guidance in a way that actually is going to work for the states. A few states have already submitted proposals kind of on a trial basis. Alaska said, you know, we really have so many, we've got to do something to lower premiums. And they did a reinsurance plan that actually lowered premiums by about 20%. So Alaska, even though it's a very high-cost state, has been able to use some of this flexibility early on to lower premiums for the people in those markets. So this is just, this was a graph, I'm sure you all have seen it, that a very hard-working staffer for the Joint Economic Committee drew as this legislation was passing to really try to understand it herself. All the boards and the agencies and the new commissions and the spending power. And you can see that the Secretary of Health and Human Services is absolutely at the center of the universe in this equation. 2,000 times it says in the legislation, the Secretary shall or the Secretary may, in really making changes to our health sector. Patients, you can see him up in the corners, patients, doctors, Congress, even the president are in the four corners, relatively irrelevant. The worst thing about this chart is, when I first saw it, I thought, oh my goodness, what a maze. There's no way anybody could ever understand that. After 7 years of being forced to learn what was in this law, I understand every one of these lines, all of the agencies, the Patient PCORI, the Patient-Centered Outcomes Research Institute, IPAB, all of the different commissions and boards, and they told me at the beginning, this was only a third of the law, and I said, that's not possible. It's only a third of the law. It's worse than this. So Congress has to come back at this. We have to free our economy from the clutches of this law that, if it's allowed to continue, is really going to significantly change the equation in relationship between individuals and their government as far as our freedom is concerned. And if this PowerPoint is useful to you in any of your own writing or work, I would be happy to send it to you. Just send me a note at gracemarie@galen.org or give me a card afterwards, and I'll be happy to send you the PowerPoint. All these slides are in the public domain. But it's really, we just have to get back to a system that puts doctors and patients in charge of healthcare services and gives you the power to choose the kind of coverage options that work for you, that do not bankrupt future generations. So thank you very much, and I think we have time for questions, Matt, yes? Thank you all.
Have time for a few questions. Please raise your hand and a microphone will be brought to you.
Thank you.
Well, you would tell us who you are before you start and where you're from, so I'll know.
Wayne Hallquist from Manchester, Michigan, about an hour east of here. Why didn't Senator Murkowski and Collins get what they wanted? It seems to me that somebody
Just
dropped
by
the ball there.
votes, right. Yeah, they actually did. They did. They were very close. I met with Senator Graham and Senator Cassidy on the 26th of September, which is the day it was pulled from the floor, at 10 o'clock. At 11 o'clock, they had a meeting with Senator Murkowski. Senator McConnell has said, it's only Alaska, how much can it cost us? Give her what she wants. And they felt that she would have been there, but when she saw that Senator Collins was absolutely not going to move on this, I think it's an ideological thing with Senator Collins from Maine. And McCain is just mad at Trump. You know, he's mad at Trump. He does not want to give him this victory. And so she wasn't going to move her vote because then it wasn't going to make any difference. But they think that Senator Murkowski would come along with they need a different story to tell. You know, really, the first bills were, we're going to do a better job of allocating federal refundable tax credits than the Obamacare bill did. This gives them a different story to tell. This says, we're going to put the control back in the hands of individuals through the medium of the states, rather than having the federal government be the know-all and do-all of health reform. But I think she's gettable. But I don't know about Rand Paul either. But if it's a different conversation, and they're facing, primary opponents, I think that we may have a different outcome early next year. We're working hard on that. We have another question here. Yes.
My name is Patricia Cox, and I'm from Poplar Grove, Illinois. I'm wondering, early on, when Graham Cassidy came out, 23 governors, or somewhere around that number, were quick to resist this plan. What was the general nature of their resistance?
And some of those were Republican governors. Almost all of them were governors who had expanded Medicaid. Remember, this bill gave states an incentive to put able-bodied adults, many of whom had either the offer or actually had private insurance through their jobs, to put them on Medicaid, and the federal government would pick up 100% of the bill. Outrageous. While it would still pay, in big states, only 50% of the cost for someone with multiple disabilities, for a seriously disabled child, 50%. But able-bodied adults, and this was all about expanding the role of government in our health sector. And so these 23 governors didn't want to give up that huge bucket of Medicaid money. California managed to figure out, just totally by coincidence, almost everybody who applied that was Medicaid eligible in California wound up applying and being able to qualify for this 100% subsidy. Who knew? Well, of course they weren't, but California figured out how to rig the rules so that now 1/3 of the people in California are on Medicaid. And so it's really shocking. 1/3 of the people in Massachusetts, I write columns for Forbes, and I was shocked to see in these prosperous states how many people are Medicaid. In Florida, 50% of all births are paid for through Medicaid. We have got to get control of this program if we are going to get control of health spending. But these were mostly Democratic governors who didn't want to lose their Medicaid money. But it's not sustainable. The federal government can't afford it, and it's ultimately, actually, the reason I wrote this piece about Massachusetts, even with this match, which goes down to 90%, even with that, they're saying they can't afford it. And so the states they're ultimately going to start squealing, and when they do, they're going to have to come to the table and say, okay, let's figure out a better deal. They could spend that money so much more efficiently if they had money. Rhode Island got something called a global waiver. It said, if you just give us the $12 billion over, imagine a little tiny state like Rhode Island could spend $12 billion on Medicaid over, I think it was 5 years, that they said, we think we'll be able to save money, both for the federal government and the states. They covered the same number of people, improved services, and only spent $9 billion. So if states had more control, they could get more value for the bucks. They just have to trust themselves and believe it, and basically be told that we can't afford this. And you saw why I put those numbers on at the beginning of the presentation. We can't afford this. This is going to bankrupt our country. It's going to rob us of our freedom. And we've got to figure out, and it has to start with entitlement spending. And Medicaid is a big part of the ballgame. So next question. Tell us again who you are.
Hi, Eric Halverson from Birmingham, Michigan. Thanks so much for being here. Although it probably won't happen politically, what are your thoughts on a bill to just repeal the Affordable Care Act and then come back to the table in a different bill to replace it?
Well, that was the original plan, you know. They twice had passed just repeal legislation and said we're going to come back to replace, feeling that that would force Democrats to the table so they would be able to pass something in a bipartisan nature. But there were just too many Republicans who were worried they wouldn't be able to do that. And even the full repeal bills still had this 2-year safety net. People were going to be able to keep their coverage for 2 years to give Congress a chance to do the full, to do some sort of replace legislation. But it just, you know, we thought that that's what they would be able to do, but it quickly morphed from repeal to repeal and replace. And the replace part of it is where they've had such a hard time building consensus, which is why I think this new platform of Graham Cassidy, returning money and power to the states, gives them a new platform to build, a new chassis for which to build new legislation. Thank you for that question. Yes.
My name is Jeff Van Havel. Thanks for coming to Hillsdale. Before I get to my question, I'd just like to say that I no longer refer to it as Obamacare. I call it Obama, Roberts, McCain, Snow Collins Care. But my question is, what sort is the right response when talking to our liberal friends when they explain to me about how beautiful things work in Europe and especially Scandinavia, about how they have great outcomes, it doesn't cost them anything, everybody's perfectly happy with it. What sort is the right response when debating my liberal friends on that topic? Thank you.
Yeah, I know, and even Bernie Sanders, right? He's talking about the utopia of Medicare for all. First of all, let's just talk about what that might mean in this country. If we were to do Medicare for all, the average couple in this country, over their working life, paying, you know, taxes into the Medicare trust fund as though there really were one. It's not a trust fund, it's a Ponzi scheme. Paying Medicare taxes their whole life will pay about $160,000 in Medicare taxes over their working life. In their retiree years, they would be expected to consume about $450,000 in Medicare services. That's a huge gap that's only filled by a continuing number of young people working to pay into the Medicare Trust Fund and not consume those services. If we were to have Medicare for all, who is going to make up that deficit? It's just not possible, which is why every state in this country that has tried to do a single-payer system. Colorado had a big initiative in 2016 trying to figure out how they were going to do a single-payer system for the state of Colorado. They found that it would increase taxes to the point that it would basically crush their economy. It would mean that everybody with employer insurance would lose it, and they would have to be on a program that looks a lot like Medicaid. And it went down 4-to-1. 80% opposed it, 20% supported it. California is now trying to figure out how they're going to do a single-payer system using this Section 1332 authority. But even with all these federal dollars flowing into the state, their new budget for health care would be more than their entire state budget for all spending on all programs. It's not affordable in this country. It's really not affordable in these other countries the way that they do it. They ration care. In Canada, if you can't find a primary care physician to take you on, you don't have access to any specialists or any care. And about 25% of people in some provinces don't. And what do? They come to the United States. We are the safety net. We're the safety valve for many people in Canada. People say, well, what other country should we emulate? Switzerland? Switzerland's program is pretty good. It's a pretty strictly enforced individual mandate at the canton level, where there's a lot of power by local officials to enforce this mandate. Switzerland has 6 million people. We have 320 million people. We're a much more diverse country. The UK, oh yes, you can get all the care you want. It's free. In the UK, if you're on the National Health Service Program and you don't have private health insurance, your chances of getting the cancer drug that you need to treat your cancer in a timely manner and getting new drugs that may actually work are significantly less than in this country, to the point that cancer survival rates for a number of different cancers are much, much lower in the UK than they are here. And it's because they ration care. People in the UK, though, don't know any different. This program has been in effect since 1948. They don't have a different option. We, in this country, are used to choices, and we're used to affordable health insurance. And yes, there have been gaps, and yes, we can fix that. But if we try to do what they have done, it either will bankrupt us, as Bernie's plan, the Medicare for All plan would do, or the California single-payer system, or Colorado's single-payer system, or we will crush the innovation. We are the laboratory for innovation for the world. If we weren't producing the new medicines and the new surgical techniques and the new medical devices, yes, there are other countries doing this, but the innovation is coming from this country. And yes, we're paying for a lot of the innovation for the world. Some of them not taking advantage of it, but this country is the engine for innovation, and what we have to figure out is how do we innovate our way into a better healthcare financing system. And it's only going to happen, I believe, by devolving power away from Washington to individuals to have more choices of coverage and to give those pharmaceutical companies an incentive to come up with a much more affordable version of a drug, something that doesn't cost $140,000, or surgical centers that can provide surgeries at a much more affordable rate, as the Oklahoma Surgical Center does. When people get outside of the web of regulation in Washington, they are able to come up with more affordable options. But as long as we have Americans exposed directly to only 11% of those healthcare costs, it's not going to happen. It's only going to happen when the American people, when that energy comes from the bottom up, with the people demanding more affordable coverage and feeling empowered to purchase it, because there are new mechanisms and new ways to do that. These temporary policies, association health plans, health reimbursement arrangement, financing is a beginning step. But we have to innovate our way out of this. There's no other country we're going to be able to copy. And by the way, the next thing they say, well, health care is a right. Don't they say that? Do you really have a right to the time and energy and investment of a physician who's spent maybe millions of dollars on equipment for his practice? I spoke yesterday with Dr. Stormy Johnson, former AMA president, a diagnostic radiologist from Metairie, Louisiana, and he said he spent $2,000 on $2 million on improved diagnostic equipment for his practice. And do we really have the right to say that somebody can just walk in and demand access to that equipment and his services and his years of training and expertise? No, we don't have that. We don't have that right. Somebody's going to have to pay him for it. And do we want the federal government to decide how little he's going to be paid to the point that he doesn't invest in that equipment in the future? And we wind up with old technology and no incentive to have him continue to develop and grow his practice.
Thank you, Ms. Turner.
Thank you all.